Hi, everyone. Good morning. Welcome to ACC 2026 Day 2. My name is Shika, and I'm a cardiology fellow at University of Wisconsin. And I have with me here the very dynamic Dr. Konstantinides, the principal investigator of HI-PEITHO trial. Dr. Konstantinides, thank you so much for taking the time out and chatting with us. So HI-PEITHO trial, as we know, did a comparison between catheter-based thrombolytic therapy with anticoagulation versus anticoagulation alone for acute intermediate risk patients. Could you tell us about the key takeaways from the trial?
Yes, thank you. First of all, thank you very much for having me. Yes, we believe that HI-PEITHO was a landmark trial because it was the first trial to compare an interventional method, a catheter-based method for treating acute pulmonary embolism with the current standard of care, not with another method. And the second, of course, which is even more important, the first trial, the first major randomized control trial to have clinically relevant endpoints as the primary outcome. And I think the key message is that it could be shown that in this patient population with an elevated risk of early decompensation or collapse or death, that a catheter-based treatment, in this case ultrasound-facilitated catheter-directed thrombolysis, was superior to anticoagulation alone because it did prevent this decompensation in quite a number of patients.
That's awesome. I mean, congratulations again. The results of the trial look promising. And this leads me to my next question, is that now that we have the results of HI-PEITHO trial and we also had recent PE guidelines released, how do you think the results of the trial is going to impact the current practice and standards of PE-related management?
Well, thank you. Actually, this is a very interesting question, which I can answer today differently than I would have 3 days ago. Why? Because we have the new ACC/AHA guidelines that introduce several risk classes, let's say additional risk classes. And one would have thought, well, now there may be some confusion. Actually, there is not, because I think what is good in the new guidelines is the fact that this so-called D1 and D2 class are those patients who are decompensating, but have not decompensated overtly perhaps yet. And it's these patients who actually, in that case, need some emergency and rescue treatment. So what HI-PEITHO shows is that when you have patients who, based on, their RV-LV ratio, a troponin test, and some clinical signs that they are quite sick, if you subject those patients to catheter-directed treatment, you prevent this deterioration that may be life-threatening. The clinical trial did not find differences in mortality because it was not designed to find differences in mortality, and no modern clinical trial can do that because it's not ethically acceptable actually to wait until patients die to declare that you have been superior. But the trial sought to find which patients came into this D category, and then there it could be found that indeed this was a significant benefit after the catheter-directed treatment.
That's awesome. Thank you so much. And then now that we have HI-PEITHO, can we expect follow-up studies in the pipeline with regards to PE management and HI-PEITHO?
Yes, and that's the good news also. I mean, HI-PEITHO is the first trial of this particular design to appear, so with clinically relevant endpoints comparing to standard of care, which continues to be anticoagulation, at least it was until yesterday. And now we will have PEERLESS 2, and we will have PE tracked, an academic study, NIH supported with long-term outcomes. We will have studies also from one European study, probably Prague 26, coming this year. And we will have a number of at least 3 to 4 trials that will actually investigate also other modes of catheter-directed treatment. Mechanical thrombectomy is also very popular in the US, and we will see what the results will be. So we are going to have very exciting news over the next months and years.
Yeah, no, certainly we are very excited for you, and we are very excited for the PE world, especially with all these excellent trials that we're looking forward to. And once again, congratulations on your landmark work. And yeah, thank you for taking out time and talking to us. Thank you, everyone.
Thank you very much. Thank you.